All right, good morning, everybody. My name is Krista Neiman. I am a volunteer with the Epilepsy Foundation. I've been with this chapter for, I think, 7 years now, and I've been involved in the community since 2003. Our next speaker will be Dr. Ryder Gwinn. Dr. Gwinn will be addressing the most recent advances to neurosurgical approaches in epilepsy. Dr. Gwinn is a neurosurgeon and the medical director of the Swedish Neuroscience Institute for Neurologic Restoration, which is dedicated to restoring the best possible functional abilities to patients with chronic neurological diseases. He utilizes advanced, minimally invasive techniques, such as responsive neurostimulation and focused ultrasound, as well as other more traditional techniques, such as deep brain stimulation, gamma knife surgery, spinal cord stimulation, and awake brain surgery. He's also the principal investigator for numerous ongoing studies to create and validate the next generation of therapies using neuromodulation and MR-guided focused ultrasound for the treatment of epilepsy, movement disorders, and pain. Dr. Gwinn is a board-certified in neurosurgery and specializes in the surgical treatment of epilepsy and chronic neurologic disorders such as Parkinson's disease, essential tremor, trigeminal neuralgia, and other pain syndromes. He graduated from the University of California, Los Angeles Medical School and completed his residency through Georgetown University and fellowship through Yale University. Please welcome Dr. Gwinn.
Thank you. Thank you, Chris, and thank you to the Epilepsy Foundation for inviting me here. Thanks to Dr. Novotny. Just as a little aside, I did my fellowship training at Yale, and Dr. Novotny was there at the time. We spent some good time together. I also worked with Dr. Vossler at Swedish for a couple of years, so I just want to let everybody know that I feel very honored to be part of a great epilepsy community here in Seattle. I think people get really good care with a lot of very dedicated physicians. So today I'm going to be talking about new interventions in epilepsy. Unfortunately, just due to the time, I'm going to be kind of at a 10,000-foot level. There's a lot more detail about everything that I'm going to talk about. We can talk about it later afterwards if you have specific questions, but probably not go into the depth that everybody would like in each one. You guys probably know epilepsy is very common, much more common than people give it credit. There are almost 3 million Americans who have epilepsy. There's 200,000 new cases diagnosed every year. 1 in 100 people, or 1% of the population, has epilepsy, and 1 in 10 will have a seizure sometime in their life. So that's really, really common. It's more common than both cerebral palsy, Parkinson's disease, and multiple sclerosis combined. So unfortunately, we don't kind of get the exposure that we'd like compared to some other diseases, but we can help to change that. So, looking into the treatment of epilepsy, we know that there's a certain percentage of people who are not going to respond to medications. Gwinn and Brody, back in 2000, published an article in the New England Journal of Medicine looking at how people respond to medications. And here it's basically showing, looking at whether or not people respond based on how many seizures they've had before they've taken their first medication. And you can see that, here, if you've had 1 seizure before you start on meds, you have about a 2/3 chance of having your seizure stop afterwards. If you've had 20 seizures before you've been put on medication, you have about a 50% chance of being cured with the medication. So it's very important to get treated, get evaluated as early as possible after it's been recognized that you have had a seizure.
Is that for all types of seizures? Because there's small ones that may not have been noticed, and they graduate to larger number.
Yeah, I mean, it really does depend. The amount of time that an individual seizure goes on for has a big influence. The type of seizure that you've had, whether it's a grand mal or a focal or an absence or partial. So yeah, this is a big generalization for sure. So here they also looked at whether or not somebody gets their seizures under control with 1, 2, 3, or 4 medications. And here you can see that patients, here we go, about 47% of patients after they've been put on 1 medication will become seizure-free. If you add another medication, if they didn't get stopped with their seizures after one and they have a second, another 13% will become seizure-free. After that, the likelihood of becoming seizure-free with a third, fourth, or more medication goes down dramatically. And about a third of patients will never have their seizures be controlled with medication. And those are the patients that I end up seeing and we evaluate in our epilepsy center. So, and as Dr. Vossler said, and as you can see with this slide here, there are a lot of medications that have been developed for treatment of epilepsy. And so if you want to, there are 29 or 32 different meds, you can try to treat with medication in a number of combinations that, could potentially spend your whole life trying new medications. And, it's not clear that any new medication is going to cure you after a number have been tried. And so I would just, again, urge people who have tried many medications to go to an epilepsy center and get evaluated to see if there's anything else that can be done. Another way of looking at it, we have 2.9 million, almost 3 million patients with epilepsy in the United States. About 870,000 have failed 2 or more medications. And about 810,000 of those patients never have an evaluation for surgical or other interventions. About 60,000 of these patients go to an epilepsy monitoring unit where they get looked at, and then about 4,000 end up getting a vagus nerve stimulator or neuromodulation, 3,000 get surgery, 3,000 get a diet or change ketogenic diet, and about 50,000 are evaluated but are not good candidates for any of those things. But the point is that only about 1 or 2% of patients with drug-resistant epilepsy ever really get a comprehensive evaluation and treatment with one of these interventions. So it's important that we get the word out about how well these things work. So before talking too much about the sort of latest and greatest in treating epilepsy with interventions, we have to go back to the most effective treatment for epilepsy beyond medications, and that's temporal lobe surgery if you have temporal lobe epilepsy. This is a trial that was done back in 2001 with a Canadian, Sam Wiebe, randomizing patients to either surgery or medication trials, and then looked at them for a year afterwards. And you could see that patients who had surgery had an almost 60% seizure freedom rate, while those in the medical group had about an 8% seizure freedom rate. So surgery for temporal lobe surgery is very, very effective, the most effective way to cure epilepsy if somebody has failed medication. So, we're trying to match this level of effectiveness with the other therapies that I'm going to be talking about today. Unfortunately, though, temporal lobe surgery and surgery in general for epilepsy can have consequences as well. There are the surgical risks associated with surgery, and that's things like bleeding, stroke, infection. We worry about that up front, but even if it's successful and everything goes well, still things can happen. There can be a change in function afterwards, and this has actually been pretty well studied. Sam Wiebe, the same group that did this New England Journal study on temporal lobe epilepsy, also looked at what's called a meta-analysis, where you look at a number of different studies across the world and kind of gather their data together and get a composite view. And these tend to be, pretty effective in telling us what the truth is. And here we're looking at neuropsychological outcomes after surgery. And we look here first at memory. First, verbal memory with left temporal lobe surgery and verbal memory with right temporal lobe surgery. Left temporal lobe surgery tends to be more risky for memory because it's on the same side that most people have language located. And so you can see here, they're looking at the number of people who gained function, got better verbal memory function after surgery, and there wasn't very many. It was about 10% or so. If you look at the number of people that lost verbal memory function, it was about 45% or so. So there's a pretty good percentage of people who underwent surgery and ended up having some decline in their verbal memory functioning. If we're talking about a right side surgery, about the same number of people gained versus lost their memory function. So it's kind of not as critical for a non-dominant temporal lobe surgery. Then they also looked at what's called visual naming and verbal fluency. So this is a test of not just memory, but also language function. And you can see here that in the study, the number of people that lost visual naming function was about 40% after surgery. And then they looked at verbal fluency, and actually the number of people that gained verbal fluency, surprisingly, after left temporal lobe surgery, actually more people gained function than lost function. And that may be related in some way to the medications being decreased and the impact that medications have had on verbal fluency. So in the end, with any kind of intervention for epilepsy, we're trying to balance things. We're trying to balance, our desire to have seizure freedom with the consequences of that therapy in terms of neurologic function. And that's really what's driven most of the innovation in epilepsy today. So if you look back to 2012 and earlier, again, there was very little after medications that we could offer patients with epilepsy. We could either offer them vagus nerve stimulator, which was out in 1997, or we could offer them open resective surgery. And this is just kind of my own way of putting these things together. The VNS is very unrisky, but it also tends to be not as effective as open surgery. Open surgery has a lot more risk associated with it, but it's also a lot more effective. And this kind of thought process is now changing with the advent of new interventions, and that includes a responsive neurostimulation, or the NeuroPace device, deep brain stimulation, which is really just coming out in the new year in 2019, laser interstitial thermal therapy, which is this laser surgery for epilepsy, so I want to talk about each of those more in detail, but we now have to think not just about really the surgical risk, but also the functional risk that goes along with those therapies. So you can see here that different therapies may split a little bit differently. DBS and responsive neurostimulation has some surgical risk, but not as much functional risk. Laser interstitial thermal therapy has a little bit more surgical risk and maybe a little bit more functional risk, but maybe not quite as much as traditional open surgery. So when you're thinking about these things, we got to think a little bit more comprehensively about the outcomes of these therapies. So what has really enabled these therapies to come along? Well, it's a lot of dedication from a lot of really smart people who are working on treating patients with epilepsy, but it's also really the immense progress in technology that we've had over the last 2 decades. And so the operating room has really dramatically changed, even in the time that I've been doing neurosurgery. We have now a lot of really good tools for visualization of actual brain structures when we're undergoing surgery. We have neuroendoscopes. We have now what's called an exoscope, which is a high-resolution camera that's above the patient and then shows on big screens so multiple people can see what's going on. We've had microscopes for a while, but the microscopes are evolving and getting better and better optics, better and better ability to track what we're doing in the operating room. And for other types of surgery, other advances such as tagging molecules and being able to visualize them through the microscope. We can also sort of put in our imaging into the microscope, so we're looking at an MRI outline of a tumor or an epilepsy focus that's laid right on top of the real visualization of the brain itself. So it's really helping us in the operating room. There's also a lot of changes in imaging. Fluoroscopy has been around for a long time, but now we have CT scans and MRI scans that are available to us in the operating room. And this has really been a huge benefit, particularly when we're placing electrodes in the operating room. We really want to know that we've done it right before we leave the operating room. In the past, we put them in, then we had to take somebody to a CT scanner down the hall, and once we see it's not in good place, it's very difficult to then bring them back and change it. Now we can get a CT scan or an MRI scan right there. If it's not right, we make it right before we leave the operating room. It's really been a huge help. Also navigation, our ability to translate what is in the virtual world, which is on the MRI scans, the targets we want to pick for electrode placement, and then translating that into the actual patient really requires a lot of software and navigation, and this has gotten a lot more sophisticated as time goes on. And then the actual delivery mechanism, how we get the electrode or the therapy into somebody's brain has evolved a lot as well. Stereotactic frames have been around for many decades here. This is the Lexel frame that we still use frequently in the operating room. There are now guidance arms that are tied to these navigational systems, and even more recently now, robots are becoming very common in the operating room, particularly to deliver multiple electrodes to the brain if we want to localize where somebody's seizures are coming from. So, when somebody comes to a comprehensive epilepsy center, they really go through a very complex process of evaluation before they ever get a surgical treatment. And so phase 1, we typically do non-invasive things like scalp EEG, imaging, PET scans. We do neuropsych testing. Phase 2 is where we try to prove where somebody's language is located, find out whether somebody's memory function is very good or very impaired by their seizures prior to surgery. But most of what I'm going to talk about here is phase 3, where we do invasive monitoring. If we haven't been able to figure out precisely where their seizures are coming from, we can actually place electrodes inside the skull, either on the surface or in the depths of the brain, to try to more precisely find where their seizures are coming from. We can also use these electrodes to map out where functions are located in the brain. And there's been a lot of progress in this area that I'll talk about. And then the phase 4, which is the surgical intervention. I talked about the temporal lobectomy right here. I'll talk more about laser. I'll talk more about responsive neurostimulation, vagus nerve stimulation, and deep brain stimulation. So this is kind of the way we used to do intracranial monitoring all the time. If we had a suspicion that somebody had, temporal lobe epilepsy, but they could also have it coming from the frontal lobe, we would very often take them to the operating room, do what's called a craniotomy, take off a piece of bone, and lay electrodes over the surface of the brain. We can also slip electrodes into other parts over the surface that are more distant, but we're kind of limited to a fairly narrow area where we're surgically opening. And it's also, it's quite invasive, it's painful to recover from, there's danger involved because, this much open surgery can lead to bleeding either at the time of surgery or afterwards. So it can be highly effective, and we still employ it very frequently, but we would obviously like to have a better method to be able to localize somebody's seizures. Today we have something that's called stereo EEG, which is a way to localize seizures not by laying electrodes on the surface of the brain, but instead by putting very small depth electrodes through the skin, through the skull, and then into the depths of the brain. And so you can see here is a patient that has had multiple stereo EEG electrodes placed, and here you can see an X-ray of those electrodes after they've been placed. And you can see that it's really kind of a different strategy that we're using with these stereo EEG electrodes. We can go pretty much anywhere in the head we want. So if we have a hypothesis that somebody has, temporal lobe epilepsy that could be on either side, we can place electrodes on either side. If we think it could be frontal and occipital, we can put electrodes, in very different places to test our hypothesis as to where the seizures are coming from. And there's some good validation on at least how safe this method is compared to the older method of craniotomy for intracranial electrode placement. This physician Cardinal in Italy did probably the biggest study so far. He looked at 500 procedures, almost 6,500 electrodes that were placed, about 13 electrodes per patient. And he found that there was about a 2.4% major complication rate. He also found that things improved over time. They actually started to use a robot in the operating room, and their error for localization of their electrodes went from about 2.7 millimeters off on average where they wanted it to go, down to 1.8 millimeters. So there's no question that technology is helping us to become more accurate, and this is important not just for localizing the seizures, but also for safety, because we're trying to avoid a lot of blood vessels as we plan these electrode placements. And so if we're off of our plan, we also may be getting close to blood vessels that we were trying to avoid. Here they looked at their complications that were associated with their stereo EEG, and they looked at both the angiography, which they did beforehand to find the blood vessels, implantation, the actual monitoring itself, as well as the electrode removal, and they found things like bleeding, as you would expect. What's called an encephalitis, or an inflammation of the brain. There was one patient who actually died during the monitoring, and one patient who had spinal fluid buildup due to a little bit of bleeding that happened in part of the brain. But overall, we have to say, okay, how safe is this compared to what we're already doing? And so they compared another meta-analysis in their paper looking at, I think, about 20 different studies throughout the world, and looked at the rates of complication, both major complications and minor complications. Found with our old method, with grid and strip placement, there was anywhere between a 0 and a 21% complication rate, whereas with stereo EEG, there's about a 0 to 2.4% complication rate. So really, on average, a much lower likelihood of having major complications. Similar finding with the minor complications, 0 to 34% for traditional, and then 0 to 2% for stereo EEG. So we know that it's probably at least as safe, maybe a little bit safer than our traditional method, but is it effective? And there's not as much evidence out there that it gets us a better diagnosis of where they're coming from and ends up with a better result for the patients. And we really need more data on that. But there is one good study so far anyway, and that was done at Cleveland Clinic with Dr. Gonzalez-Martinez. He's really been kind of the biggest proponent of stereo EEG in America. It's been done in Europe for a long time, over 20 years now, but it's really taken off in the United States over the last 5 years, and the Cleveland Clinic has kind of been the earliest adopters for this kind of surgery. And they looked at 100 patients that had very difficult to localize. So their hypothesis was that there was at least 2 different lobes of the brain that the seizures could be coming from. And so they implanted 96 patients and then did 75 resections, meaning that they went to surgery to actually have a therapy in 75 out of those 96 patients. They had 53 of those patients had 1-year follow-up, and they found a 62.3 seizure freedom rate in those patients at 12 months, which is actually a very good outcome for this very difficult population. So we know at least that there's a possibility that we can get very good outcomes with this type of approach for localizing seizures. So that's stereo EEG. I want to move on to now the therapies that have been advancing for treatment of epilepsy. Vagus nerve stimulation has been around for a long time. It was FDA approved in 1997. It can be used in patients 12 or older with now, as Dr. Vossler said, focal onset seizures. We're not using partial anymore. And there have been some changes in the vagus nerve stimulator over the years. The biggest sort of advance, I would say, is with the Aspire SR model that has come out in 2015. This has a new, what's called an auto stim mode, where the device itself can listen to the patient's EKG or their heart rate, and some patients with seizures will have an increase in their heart rate as their seizure starts, and this device can pick up that rapid rise in heart rate associated with the seizure and then deliver an extra stimulation that might be stronger than the regular background stimulation in an effort to stop that seizure, or perhaps make it shorter or have a shorter recovery period because of that stimulation. It's similar. The VNS already has a magnet stimulation. You can already activate an extra stimulation by swiping a magnet, but a lot of patients don't know when they're having seizures or may not have access to their magnets, so this is a way of delivering extra therapy when it's needed. And There's another model that's just come out last year called Sentiva that also has that feature associated with it, but has some additional features. I think the most important of which is the ability to vary the levels of stimulation. You can adjust it to have one level of stimulation at night, another one during the day. So some people may have more frequent seizures at night. You might want to turn it up at night. Some patients may have sleep apnea, and vagus nerve stimulation can make that worse at night, so we can turn it off at night or turn it down at night now if we want to. There's also some easier kind of programming associated with this. We can set a patient to automatically increase the level of stimulation over a couple of week period of time. This is important right after it's put in. Some patients live very far away, and it's difficult to bring them back again over and over again to have their device adjusted, and so we can kind of put them on this automatic protocol for increasing stimulation. They did a trial of both an American and European trial. They looked at the combination results here. This is looking at the 3-month here in the green and the 12-month outcome with this auto stimulation. And they looked at the responder rate, which is the number of patients who had a 50% or better improvement in their seizure frequency, as Dr. Vossler also referred to. And they saw that 22% of patients met that 50% reduction criteria at 3 months, and 38% met that reduction criteria at 12 months. And so this is actually fairly similar to the outcome of the regular vagus nerve stimulator as well. So at least at this point, there's not very good evidence that the auto stim helps control seizures better, but certainly there's a lot of us who think that there's the potential for that, and there are a lot of, I think, improved features that might help make the programming a little bit easier for the patient. Laser interstitial thermal therapy, another name for this. People call Visualase is the name of the company that makes the most popular device. We can also call this laser amygdalohippocampectomy, which is kind of a complicated term. But lasers have actually been around for a long time in neurosurgery. First one was used in the brain in 1966, and then Sugiyama in 1990 first described its use for treating brain tumors. But now I would say its most popular use is in treating epilepsy. As I said, this company Visualase got approved in 2007. This device is approved for treating brain lesions. It's not specifically approved for treating epilepsy. We can kind of use it anywhere we want for whatever purpose, but there's no epilepsy indication for it yet that's approved by the FDA. But there is a trial underway right now called the SLATE study to look at comparing the use of this laser in temporal lobe epilepsy, comparing it to traditional temporal lobectomy surgery to see if there really is a head-to-head benefit to the laser. There's another company called Neuroblate. There are some differences between them, the wavelength of the laser energy, how the laser energy is cooled, whether it's saline or gas. The size of the catheter is actually different. This is about 3 millimeters. It's a little bit bigger catheter that's placed in the brain than the Visualase. There is some ability to steer the laser energy, though, with the Neuroblate that's not available with the Visualase. These are kind of technical differences between them. But what's so appealing about this therapy is that we can place a laser catheter into the brain through a very, very small twist drill hole in the skull. Rather than having to do a big craniotomy, it's about a 3 millimeter hole instead. And then we can place the catheter, and as you can see here, we then take the patient to the MRI suite, and the surgery or the therapy is applied under direct visualization or indirect visualization with the MRI scanner. So we can actually look at the temperature of the brain very precisely in real time to see how our lesion is evolving. And you can see here, this is sort of what we call a thermal damage map, where we can move the laser, kind of pull it back along the trajectory that we placed it, and treat the structures. Here we're treating both the amygdala and the hippocampus, which is the most common place seizures are coming from in temporal lobe epilepsy. And you can see that, you know, we can treat that area very deep in the brain without touching the more superficial parts of the brain, which we would have to go through with an open surgery. So we can be very much more targeted with our surgical approach with this device. There are some limitations. We kind of have to go along a straight line during our treatment. We can place more catheters if we want to make a more complex treatment paradigm, but there are some limitations with it as well. But what's nice is that we can use the temperature heating of the laser to create either a reversible lesion, so we can turn it up to about 45 degrees centigrade, which is not lethal, and verify that this heating is happening in the place that we want it to be happening before we actually deliver a level of temperature that's going to cause injury to those tissues. So again, we can just watch and be much more careful about making sure that we're treating the right areas. There's some evidence out now about how effective laser interstitial thermal therapy is for patients with epilepsy. This is class 1 seizure-free rate, or just having auras after a number of months after the treatment with the laser. And you can see here that patients on average have about a 40% seizure-free or class 1 outcome more than 20 to 24 months afterwards. So again, we're talking about 60% or so, maybe a little bit better with temporal lobectomy. We're looking at about 40%. There are other studies that say it's closer to 50. That's really why we're doing this SLATE study now, is to find out more precisely what are the differences in seizure freedom and in terms of functional outcome between these two therapies. They also have the Emory group with Dr. Gross has looked probably more than anybody at this technology, although University of Washington and Dr. Ogeman also participated in these studies. And they have compared now the laser treatment to the traditional temporal lobectomy. They didn't have a direct comparison group. They used what's called a historical control. But they looked at what's called Boston naming, and this is really, again, a language function test. And you can see that almost everybody had a worsening language function after temporal lobectomy, whereas, if you go up, that's better. With the laser, there was a much smaller decline in Boston naming in most patients compared to temporal lobectomy, and in fact, in a couple patients, it got better. If you look also at face recognition, so asking people if they recognize famous people, it's a little bit more mixed with temporal lobectomy, but some people got better, but more people got worse than better, whereas with the laser, almost everybody got better with this treatment. So perhaps a little bit less effective, but also, I would say, very likely to be an improved functional outcome in terms of neuropsychological testing afterwards. Next, I'm going to talk about the responsive neurostimulation, or NeuroPace. This device was approved in 2013, and it is basically a device that's implanted in the skull, and you can attach two different leads to it. It can either be a depth lead that goes into the brain, or what we call a strip lead that goes over the surface of the brain. We can put it anywhere we want in the brain, and it has a microprocessor, it has a memory unit, it has a stimulation and sensing component, so we can both listen to the brain and treat the brain at the same time. And the idea is that that device will be placed over the area or in the area where the seizures are occurring, listen to brain activity. When it sees something abnormal, i.e. a seizure happening, it tries to stimulate and abort that seizure before it spreads to the rest of the brain and causes what we call a clinical seizure. The patient has a change in their behavior because of their seizure. And so again, it constantly monitors brain activity. When it detects a abnormal pattern, which we define it in the office, but then the device does it on its own afterwards. So it's continuously monitoring even when the patient's at home, and then it stimulates when it finds a trigger for this automatic stimulation. It can also record patients' seizures so that we have a lot of data now about individual patients when they're having their seizures, what those seizures look like in an electrographic way. We can compare that to how much medication they're taking, what they're doing in their lives. So we have kind of a new seizure monitoring system that we're only now taken advantage of in other ways beyond just the stimulation. We don't have enough time to talk about that, but it is a fascinating topic. This device, as I was saying, is very sophisticated. We can determine how many detections or how many therapies it's provided in every hour of the day. We can do it by day of the month. We can see that some people have much more frequent detections and frequent stimulations at certain times of the day. We may want to change their medications or may want to change the therapy of the RNS. We can also now, as I said, record somebody's actual brain activity and look at it online as physicians and use this brain activity electrocorticography to make changes to the device to hopefully tune it better, to recognize their seizures better, and to treat their seizures more effectively. There were a number of trials back in 2004 to 2012. There was a feasibility trial, the pivotal trial, and now a long-term follow-up trial. I don't want to go too much into that because it's kind of it's approved by the FDA. They were very well designed and instituted trials. They were, double-blind patients, and many of the doctors didn't know whether the patients were having therapy turned on or not. And so it was, I think, a class 1 study, meaning it had the highest level of scientific rigor associated with it. And we found that certainly after 3 months, the patients who had the device turned on did better, no question, in terms of their seizure counts than the patients who did not have the device turned on. That's why it was approved by the FDA in 2013. Looking now in an open label way, this is not blinded anymore, so there's not as good of a scientific rigor associated with it, but we're seeing about a 65% reduction in patients' seizures frequency compared to baseline, compared to before it was implanted. Even 6 years out afterwards, there's now another paper showing that it's very similar even 8 years after it's implanted. And so there are not, I would say there's not one patient who has never had a seizure after it was implanted in any of the studies that were done. So this is not what we typically call a curative therapy, but there are many patients who have had very long prolonged seizure-free periods. 13% had 1 year or more that were seizure-free, 23% 6 months. I have a couple of patients who are now many years seizure-free with the device implanted, but they did have seizures after it was implanted. Some of them have had it now for 8 or 9 years. Looking at quality of life, with this trial, there were subjective improvements in quality of life that were noted at year 1 and year 2. There were cognitive improvements, mental health improvements, physical health improvements. There were also, more importantly, no diminishments in any of these categories of either memory or language function after the device was implanted throughout that blinded period of the trial. So in summary, for what we can use today, for localization epilepsy, stereo EEG now represents a minimally invasive way of localizing seizures. It is not minimally risky, though. People can still have hemorrhages. They can still be very, very impactful if those hemorrhages occur. As I mentioned, one person died in the trial from Cardinal, and every center who does this frequently will see some percentage of patients who have some bleeding with this. So it's very nice. It's very minimally invasive and easy for the patients to go through, assuming nothing goes wrong. And now with these minimally invasive treatment options, either with laser interstitial thermal therapy or the responsive neurostimulator, we can now effectively treat their epilepsy without ever performing a craniotomy. And this is really, to me, an amazing change in how we treat patients with epilepsy using surgery. Surgery used to mean taking off a piece of bone, doing a very big operation. Now we can really get people in and out very quickly, very easy to recover from, and if it works for them, it's really magical. But it's not for everybody. So I want to talk a little bit about deep brain stimulation. It's really not available yet. It's been studied for a long time now. A lot of different targets in the brain have been studied with deep brain stimulation, but the anterior nucleus of the thalamus was the one that was really focused on for a major trial. This trial was performed back around 2004 to 2007, so it's actually an old trial now. It's called the Sante trial. It's stimulation of the anterior nucleus of the thalamus for epilepsy. This was headed up by Dr. Fisher from Stanford, and it was done really almost simultaneously with the NeuroPace trials. There were 17 centers, 110 patients implanted, and it was also for a very similar population of patients that the NeuroPace. They have to have partial onset seizures, failed 3 or more medications, 6 or more seizures per month, and they basically showed that patients 3 months after the stimulation was turned on were doing better than patients. This was also a blinded study, so patients with it turned on, the seizure rate went down after it was implanted. It stayed down if the patient was turned on. Patients who had sham stimulation, they had their seizures decrease initially, usually because of anything we do in surgery has the potential to kind of change seizure frequency for a little bit, but it tends to then go back to the way it was. So those patients had a decrease in their seizure frequency, but it was only temporary. And so there was a difference between them. Whether or not it was a significant difference has been kind of an argument over the last 10 years, and that's why it took so long for the FDA to approve the treatment. The NeuroPace last trial, we waited longer before randomizing patients to kind of allow for that surgical effect to wear off before the trial started. This trial did not have that with it, so that kind of clouded the water a little bit. Also, there's one patient in the test group who had a lot of seizures, and then they changed the paradigm of stimulation, and the seizures got much better, it even stopped, but those seizures had to be counted, and it kind of threw off the numbers for the whole trial. So there are also some side effects of deep brain stimulation. There were noticed surgical effects with the trial. They did have some hemorrhages, some infections, as we'd expect, but the infection rate was a little higher, almost 13% that we would expect. They also did find that there was a change that was measurable in the patients who were stimulated versus the sham patients in terms of depression and memory impairment. So not entirely sure that this doesn't have a functional consequence associated with it. The overall outcome was actually fairly similar. They now are following it 5 years out. They have about a 65% reduction in seizure frequency, which is actually fairly similar to NeuroPace. So in conclusion, I'll just talk about some minimally invasive approaches that are also kind of on the horizon. Gamma knife radiosurgery has actually been studied for a while now. There's a national trial to treat epilepsy, temporal lobe epilepsy with radiation. It really has kind of fizzled out. It's not used frequently today, but it is something that can still potentially be used in the future. Stereotactic radiofrequency thermocoagulation has actually been around for a long time, but it's kind of making a little resurgence now because we can very accurately, again, target areas of the brain and deliver those thermal therapies. And then MRI-guided focused ultrasound is very interesting to me. We do this now at our institution for patients with essential tremor. We're looking at targeting it for Parkinson's disease right now, but I think it holds a lot of promise for treatment for patients with epilepsy as well. We did a little cadaver study where we tried to treat cadavers with in the mesial temporal lobe to just see if we could create lesions. This is basically a technology where we're using sound waves to focus the energy at a certain part in the brain, completely non-incisional. It's not non-invasive because the sound waves do go into the brain, and we do heat the tissue at the source, but it's a way of not having to put any probe or any electrode or any catheter into the brain and still deliver therapy. So, last slide. Looking at kind of modern day treatment algorithm for people with medically refractory seizures. First, we need to know, is it localized? If it's not, we can employ things like the vagus nerve stimulator or deep brain stimulation. If it is localized, then we kind of go down this pathway. We ask, how many foci are there? How many different areas are there that are causing the seizures? If there's only one, we ask, is it safe to remove that area? Are there a lot of functional consequences? And is it likely to be curative? And if all of that is yes, then we would go to either the laser or open surgery. If they have two foci, if there's more than one focus and we feel like we can't treat them both with surgery, we're most often using this responsive neurostimulator today. And there's a lot of kind of combination therapies that we can do. We can treat with open surgery or laser, and then if that isn't totally effective, then employ one of these other modalities as well. So I'm really excited about the number of different tools that we have available today. We still need to study these a lot better. We still need to make them more effective. Hopefully we can get them to the point where they're getting people seizure-free at the same rate that open surgery does, but still have a much lower functional consequence associated with them. So thank you very much. Oh. So any questions? Yeah.
I have a question. Right here. So in the last 5 years, since it was NeuroPace did the 2003 neurostimulator, what happened in the last 5 years that makes it so popular now? I mean, why did it take them 5 years to be so much more popular
The
now?
NeuroPace you're talking about, the responsive neurostimulator?
The RNS.
Yeah, it was approved in 2013, 5 years. It has been around a little while. It's a good question. I would say it's has to do with the number of implanting centers. You know, there were 8 centers involved in the initial feasibility trial, 32 centers involved in the pivotal trial that made it approved. But it's a complicated surgical procedure. It's not easy to do. There's not a lot of neurosurgeons that are trained to do it right, and it takes time to really get the whole population of epilepsy centers and people who perform these treatments up to the level that it's needed, really. There's also, you know, with any new therapy, there's kind of increased awareness over time and also increased evidence of its effectiveness. So I would say that, you know, 5 years actually isn't that long when it comes to these kinds of therapies. You know, I would say that any level 4 epilepsy center, National Association of Epilepsy Centers, has known about this really since its approval. Not every level 4 center has had that availability, but I think there's more than 130 centers now that are doing this implant. It's becoming a lot more popular. Again, I don't want to, you know, say that this is the best thing ever. I think it's a very effective tool for improving seizure control in a selected number of patients. The key is that we have to know where their seizures are coming from if we want to employ this effectively. And that really requires more than anything that the patient come to a advanced center where they can undergo a comprehensive evaluation so we can actually figure out where their seizures are coming from. Yeah.
Yeah, I had a question. It looked like you had listed some age recommendations for the VNS and the RNS that were a little bit older when it comes to pediatric epilepsy. For patients that are much younger and have been non-responsive to AEDs, like how would you go about evaluating some of the non-pharmaceutical options for much younger patients?
Sure. Yeah, I was just talking about the FDA indications. You know, as Dr. Vassar was saying, with medications, you can use any medication you want that's approved by the FDA for any diagnosis that you want, but you just have to inform the patient that you're using it in an off-label fashion. Same thing goes with these devices. Right now, it's for VNS, it's approved for 12 and above. For the RNS, it's approved for 18 and above. But we can still use it in younger patients. And in fact, the vagus nerve stimulator.
VNS is now approved to age 4.
Oh, age 4. Okay, I'm sorry, I didn't even know that. But for a long time, we've been using it in patients who are much younger than 12. And the RNS, in fact, has been used in patients who are under 18. But the insurance the insurance approval and payment for it has not kind of become as widespread as it has become for VNS. So there are very few patients for whom it has been employed under 18 so far, but it definitely has been used.
All right.
Yeah.
So for the sake
Kevin?
of time, we're going to go
There's
to.
one more question.
Oh,
Can we do it real
okay. Make it quick. John. I know this guy. I can pick on him.
I appreciate that. Hi. Are there any studies to show if there's any differences? I currently have a VNS that I've had since 2005. It's not currently operating anymore. These new ones that are coming out. Are there any data showing that there any information or studies showing that people who I'm sorry.
No problem. Take your time.
Showing that the new what are the one that
The
came
Sentiva.
out Sentiva
Uh-huh.
has any better works any better for people than the old
Yeah.
one.
Very, very little data, I would say. The studies that they did showed that the autostimulation feature can actually pick up the heart rate increase and provide an extra stimulation in a relatively specific fashion. You do have to train the device to kind of say when it's going to turn itself on. And so people who exercise also have an increase in their heart rate. And so there's sort of this false detection rate versus a real detection rate for seizures. And they did show that there was some ability to provide fairly specific stimulation when patients are having seizures. But they have not shown, at this point, to my knowledge anyway, that it is controlling their epilepsy any better than the older VNS.